Imagine going to a mechanic with a car that is just violently shuddering.
Right.
I mean, the engine is knocking, smoke is billowing out from under the hood, and you're frankly terrified it's going to stall on the highway.
Oh, absolutely.
And the mechanic takes one look at a single, totally unpredictable dial on the dashboard, taps the glass, and says, well, the dial says you have a full tank of gas. The car is perfectly fine.
It's completely absurd. I mean, you would never accept that for a vehicle.
Never. But, right now within the NHS, that exact scenario is happening to thousands of women over the age of 45.
Yeah.
You've gone to your GP experiencing completely debilitating menopausal symptoms, only to have your concerns just, dismissed, brushed off, or met with reliance on faulty testing and totally outdated advice.
And for the patient sitting in that consultation room, I mean, that dismissal translates directly into prolonged, unnecessary suffering. It's incredibly invalidating.
Exactly. Which is why today we're going on a very specific mission. For this deep dive, we are taking a massive stack of NHS policies, clinical guidelines, and advocacy frameworks, and we're going to map out exactly what your clinical and legal rights are.
Right, because you need to know where you stand.
Exactly, especially when you are facing a dismissive GP regarding menopause. We are basically building you a step-by-step toolkit because, honestly, you shouldn't have to just accept a brush-off.
You absolutely shouldn't. And to start building that toolkit, we kind of have to look at the ultimate rulebook, which is the NHS Constitution.
Okay, the NHS Constitution.
Yeah, it was created in 2009, and this document acts as a single summary of your legal rights as a patient.
Right.
And one of the most critical rights outlined in there is your right to drugs and treatments that have been recommended by NICE. That's the National Institute for Health and Care Excellence.
Assuming your doctor agrees they're clinically appropriate.
Exactly. If they are clinically appropriate for you.
Okay, I want to jump right into that because the NHS Constitution is this really broad legal framework that says, you have a right to good care.
Right.
But the actual manual your GP is supposed to use to determine what is clinically appropriate, well, that comes directly from NICE.
It does.
And I was reading through the specific NICE guideline for menopause, which is known as NG23 in the sources, and it is shockingly straightforward compared to the hoops women are currently being forced to jump through.
It really is. NG23 is incredibly clear. It basically says, if you are an otherwise healthy woman over the age of 45 experiencing menopausal symptoms, your diagnosis should be purely clinical.
Purely clinical,
Yeah.
meaning based entirely on what you are telling them.
Yeah.
Your symptoms, your physical reality, your history.
Right. Not a machine, not a lab result.
And yet, the sources highlight that primary care services are still relying really heavily on blood tests to diagnose menopause.
Yeah.
Specifically, these FSH laboratory tests, follicle-stimulating hormone.
Yes, and this is a massive point of friction right now between patients and doctors. Crucially, the NICE guidelines explicitly state that GPs should not use FSH laboratory blood tests to diagnose perimenopause or menopause in women aged over 45.
They explicitly say not to use them.
Exactly. The evidence shows these tests are practically useless in this age group, but they're still being ordered constantly.
But why are they useless?
Yeah.
Because, I think there's this really ingrained assumption we all have that a blood test is the ultimate objective truth.
Right, like it's a definitive answer.
Yeah. If a lab says my hormone levels are normal, how can it be wrong?
Well, to understand why it's misleading, you have to look at the biological mechanism of what is actually happening during perimenopause.
Okay.
So FSH, or follicle-stimulating hormone, is essentially a chemical messenger. It's basically your brain shouting at your ovaries, telling them to produce estrogen and release an egg.
Okay, so brain shouts at ovaries. Got it.
Right. And in a typical reproductive cycle, the ovaries respond, estrogen levels rise, and the brain quiets down.
Simple enough.
But during perimenopause, the ovaries become highly unpredictable. Sometimes they respond, sometimes they don't.
Oh, okay.
So the brain starts shouting louder, which means your FSH levels spike. But then, a few days later, the ovaries might suddenly produce a massive surge of estrogen, and the brain drops the FSH levels right back down to normal.
Oh, wow. So your hormones are just fluctuating wildly day by day or even hour by hour.
Precisely. So, taking a single FSH blood test during perimenopause is like taking a single photograph of a roller coaster and trying to guess the average speed of the entire ride.
That's a great way to put it.
Yeah, it's just a meaningless snapshot. If you happen to take the blood test on a day when the brain has momentarily quieted down, the test will come back quote-unquote normal.
Which brings us right back to the broken fuel gauge on that sputtering car.
Exactly.
It's totally unnecessary, and if the gauge randomly says the tank is full, the GP looks at that broken dial and says, well, the test says you're fine. You can't be in menopause.
Yeah, it must be anxiety or whatever else they suggest. And the cost to the healthcare system from doing this is staggering. The guidelines point out that running these FSH tests is a massive waste of NHS resources.
I can imagine.
But the real tragedy is that it leads to false negative results, which then delays the patient from getting access to highly effective treatments like hormone replacement therapy or HRT.
Which they desperately need.
Right. There was actually a local quality improvement initiative mentioned in the sources, and their goal was to reduce FSH testing in the over 45s from 70% of all tests down to 15%.
Wait, 70%. That shows you just how widespread the overuse of this test really is.
It's systemic, yeah.
Okay, so we have incredibly clear guidelines. No blood tests over 45. Diagnose based on symptoms.
Huh.
Offer HRT first line for vasomotor symptoms like hot flushes.
Right.
If it's this explicitly clear on paper, I have to ask, why is there such a huge disconnect? Why are so many GPs flat out refusing to discuss HRT or actively minimizing these symptoms?
Yeah. Well, to really understand the GP's mindset, we kind of have to look back at a massive medical trauma that occurred back in 2003.
Okay.
There was a major study published in the U.S. called the Women's Health Initiative, or the WHI.
Right, I saw this mentioned in the sources. They said that after this data came out, prescribing for HRT essentially stopped overnight. It fell off a cliff.
Yeah.
But what actually happened in that study?
So the WHI was originally designed to see if HRT could prevent heart disease in older women. But the trial was stopped early because the researchers suddenly saw what looked like an increased risk of breast cancer, heart attacks, and strokes among the women taking a very specific combination of estrogen and progestin.
Oh, wow. So they just shut the whole thing down.
They did, and the media absolutely ran with it. The headlines were terrifying. The medical establishment panicked.
So doctors were suddenly terrified that they were going to give their patients cancer or, cause a heart attack by prescribing HRT.
Exactly. But here's the critical flaw in that 2003 study, the how and why, that has since been really heavily nuanced by later research. The average age of the women in that WHI study was 63.
Wait, 63?
Yeah. Many of them were 10 to 15 years past the onset of menopause. They already had underlying cardiovascular disease.
Oh my gosh. So they were testing it on a completely different demographic than the typical 45-year-old woman just starting perimenopause.
Exactly. They took the generalized risk of 60 and 70-year-old women and applied it to healthy women in their 40s and 50s.
That's wild.
It is. And we now know about the timing hypothesis, which shows that starting HRT around the onset of menopause actually has protective benefits for the heart. And the breast cancer risks were vastly overstated for the average healthy woman.
But the damage was already done.
Yeah, that 2003 panic basically scarred an entire generation of doctors.
So you have a patient who is suffering, sitting across from a GP who is operating on 2-decade-old, totally debunked fears.
Right.
Let's say you're in that room. You are armed with the knowledge that your diagnosis should be clinical. You tell them, look, I don't need the FSH blood test. But your GP is still stuck in 2003. They're terrified of HRT, and they're just dismissing your experience entirely.
Yeah.
What is the immediate next step for that patient?
The very next step is you need to invoke your right to a second opinion. Getting another set of eyes on your case is your first tier of escalation.
Okay, I want to explore this second opinion thing because the sources had a really interesting contradiction.
Oh, about the legality of it.
Yes. They state that I have a right to a second opinion, but the fine print basically says it isn't a statutory, legally binding right.
Great.
So how does a non-binding right actually work in practice? If I ask my GP for a second opinion, do I just have to cross my fingers and hope they're having a good day?
I know, it's a fascinating quirk of NHS policy. You are correct. You don't have a strict statutory legal right to a second opinion in the same way you have a legal right to, say, view your own medical records. However, you are protected by professional regulation. the General Medical Council, the GMC, which licenses and regulates literally all doctors in the UK states in their good medical practice guidelines that doctors must respect a patient's right to seek a second opinion.
Ah, I see. So it's a professional obligation. If they refuse, they are technically violating their own regulatory body's code of conduct.
Precisely. The Department of Health and the British Medical Association both consider it fundamental good practice. Your GP should be understanding and just arrange it for you unless they have a remarkably good reason to justify a refusal.
And in the case of ongoing unresolved menopausal symptoms?
A refusal would be nearly impossible for them to justify to a medical board.
Okay, that is incredibly empowering to know. And under the NICE guidelines, when should a GP be proactively referring you out to a specialist anyway?
Well, NICE Guideline NG23 says a referral to a healthcare professional with specific expertise in menopause should be done if treatments aren't improving your symptoms, or if you are experiencing ongoing, troublesome side effects from the medication.
Okay, so if it's not working, they need to escalate it.
Yeah. It also says they should consider a referral if you have menopausal symptoms, but HRT is contraindicated. For example, if you have a history of hormone-sensitive breast cancer, or if there's just general uncertainty about your treatment options.
You know, my immediate instinct, if I hit a brick wall with my local NHS clinic, is to just bypass them entirely and pay out of pocket for a private menopause specialist.
A lot of women do that.
But I'm genuinely terrified that if I step out of the NHS to pay for private care, my GP will just wash their hands of me, and I'll somehow lose my NHS coverage or my right to NHS prescriptions. I mean, is that a real risk?
It's a very common fear, actually, but it is a complete misconception.
Really?
Yeah. The British Medical Association guidance makes it unequivocally clear. A patient who requests a second opinion within the private sector can absolutely continue to access their other NHS services. You do not void your NHS rights by seeking private counsel.
Oh, wow. That is a huge relief.
You would just ask your GP for a referral to a private specialist, or honestly, you can consult some private GPs directly without a referral at all.
Good to know.
Just keep in mind, if you need your medical records sent over to the private doctor, you have the right to access them, but your NHS practice has up to 28 days to provide them to you.
Right, so factor in some waiting time there.
Yeah.
Okay, so let's say you've tried bringing up the NICE guidelines. You've asked for a second opinion. But what if asking just creates massive friction?
Right.
What if your GP practice outright refuses to accommodate your choices, they won't refer you, and they just continue to mismanage your care?
Well, when the clinical route fails, you have to kind of shift your mindset. You stop acting solely as a patient and start acting as a consumer who is holding a service accountable.
Ooh, I like that shift.
Yeah. It is time to invoke your formal rights under the NHS Constitution, specifically the right to complain and have that complaint properly investigated.
Which, honestly, sounds incredibly daunting.
Yeah.
But the sources map out a very clear pipeline for this. And before you start writing formal, intimidating legal letters, there is actually an informal mediation route.
Yes. You should definitely look into the Patient Advice and Liaison Service. It's commonly known as PALS if you're in England. And in Wales, a similar function is provided by an organization called LAY.
Right. I've seen signs for PELS in hospital corridors, but it always felt a bit like a suggestion box. Do they actually have any teeth?
Think of them less as a suggestion box and more as a rapid response mediation team.
Oh, okay.
They act on behalf of patients to liaise with staff and managers to negotiate really speedy solutions. If there's a logistical problem that requires a quick fix, like a delayed referral or a severe breakdown in communication, they are your absolute go-to. They also act as an early warning system for the NHS, capturing localized trends of bad service.
But they can't overrule a doctor's actual medical decision.
Right. Correct. And that is their main limitation. They cannot offer clinical advice, and they do not investigate formal complaints about clinical conduct.
Right. They're mediators, not medical directors.
Exactly. So if your issue requires a deep dive into why the GP is actively ignoring NICE guidelines, the mediation team will just redirect you to the formal complaints process.
Which brings us to the formal complaint itself. And here's where we need to highlight a major structural update, because the rules for primary care complaints changed fundamentally quite recently.
Yes, this is a crucial piece of the toolkit. As of July 1st, 2023, the way you make a complaint about primary care services, which includes GPs, changed entirely in England.
How so?
Well, previously you could complain to this massive centralized body, NHS England, but now the system has been localized.
Got it.
So you basically have two choices. You can complain directly to the healthcare provider, which means the GP practice manager, Or you can complain to the local funding board, which is known as the Integrated Care Board, or ICB,
Okay, I have to question the logic of that first option.
the practice manager.
Yeah, because if my GP is the one dismissing my symptoms, why on earth would I complain to that GP's boss, the practice manager? Isn't that like complaining to a restaurant owner that their own chef's cooking is terrible? They're just going to defend their staff. Why wouldn't I always go straight to the local funding board?
It feels incredibly counterintuitive, I completely agree. But complaining locally to the practice manager is actually recommended by the NHS as the first step for one specific reason:
Gotcha.
speed. Practice managers have the immediate, on-the-ground authority to instantly change your designated doctor within the surgery. They can arrange that specialist referral you've been fighting for or authorize a medication review right then and there.
Ah, I see.
To use your analogy, the restaurant owner might quickly replace your meal just to keep you from leaving a terrible public review or escalating the issue to the health inspector.
Okay, that makes total sense from a purely practical, get it done quickly perspective.
Exactly. However, if the relationship has entirely broken down, or if you feel the practice manager is just closing ranks to protect the GP, well, that is exactly why the alternative exists. You bypass the surgery completely and go to the local funding board, the ICB.
And why does the ICB have leverage over my doctor?
Because of how the NHS is structured financially, the local funding board is the organization that actually commissions and pays for the GP services in your area.
Oh, they control the purse strings.
They control the budget. So when the people paying the bills start asking questions about why a clinic is systematically ignoring NICE guidelines and generating patient complaints, the clinic has to listen. It introduces an entirely different level of accountability.
Okay, so you've gone to the practice manager or you've escalated to the local funding board. What happens if they investigate but they just send you back a generic boilerplate letter? We've reviewed your case and find the GP acted within appropriate parameters, but you are still sitting there with debilitating joint pain and hot flushes.
You do not have to stop there. If you are unhappy with the final response from the provider or the funding board, you have the right to take your case to the National Ombudsman.
The ombudsman, that is the final tier.
They are the ultimate independent judges for complaints. In England, it's the Parliamentary and Health Service Ombudsman. Scotland and Wales have their own equivalent independent bodies.
And they're totally separate from the clinics.
Yes, they exist completely outside the NHS structure. Their whole purpose is to objectively investigate whether you were denied your legal rights under the NHS Constitution.
Okay, taking a step back for a second, I'm just reflecting on the immense physical and emotional toll this takes.
It's massive.
I mean, when you are suffering from perimenopause, when you have severe brain fog, you haven't slept in weeks because of night sweats, your mood is completely bottomed out, fighting a bureaucratic battle through mediators, practice managers, local funding boards, and an independent ombudsman. It's exhausting just talking about it.
It is a profound systemic failure that patients are put in this position when they are, frankly, at their most vulnerable. But this raises a really vital point. You do not have to fight this battle alone.
Yes, the advocacy sources.
Exactly. The sources highlight several advocacy organizations that exist entirely to support patients through this labyrinth, and they are completely free.
Tell us about the actual support available, because this is huge.
So organizations like Swan Advocacy, the Advocacy People, or the Patient and Client Council in Northern Ireland, these aren't just helplines that listen for 5 minutes and, email you a PDF brochure.
Right.
They provide actual human advocates who will help you navigate the NHS Constitution. They will draft the formal complaint letters on your behalf, and most importantly, they will actually attend meetings with you and the healthcare provider.
Having a professional advocate sit in that room with you, taking notes, while you confront a dismissive GP or practice manager, that completely alters the power dynamic in the room.
It neutralizes the intimidation factor immediately. They ensure the service responds to your complaint properly, and they can support you all the way up to the ombudsman if necessary.
That is incredible. And there is one final, ultimate right we have to mention, which is found in the NHS Patient Choice Charter. Because sometimes you just have to walk away.
Yes. If a practice is fundamentally failing you, you have the right to choose your GP practice and change doctors entirely.
You could just leave.
As long as the new practice is within your geographical boundary and they have the capacity to take on new patients, you can simply leave. Your old practice is legally required to transfer your medical records over. Sometimes the most effective advocacy is just firing your current doctor.
Firing your doctor. I love that. Okay, we have covered a massive amount of ground today. Let's do a quick recap of the toolkit we've built for you.
Let's do it.
First, know the science in your clinical baseline. The NICE NG23 guidelines clearly state that for healthy women over 45, menopause diagnosis is clinical, based on your physical reality, without the need for unreliable FSH blood tests.
Second, if your GP isn't listening, demand your second opinion. The General Medical Council dictates that doctors have a professional obligation to respect this request.
Third, if you hit a wall, use the complaints pipeline. Start with the Rapid Response Mediation Team, PLS or LAY, for a quick logistical fix.
Fourth, if it needs to be formal, remember the July 2023 structural update. Go to your practice manager for speed, or directly to your local funding board for financial leverage. And if they fail you, escalate to the independent national ombudsman.
And finally, don't do it alone. Bring in free advocacy services to alter the power dynamic, or simply invoke the NHS Patient Choice Charter and change GP practices entirely.
It is a highly effective structural toolkit. You really are no longer in the dark.
But looking at all this, it leaves me with a thought about the future of this entire process. We've spent this whole deep dive talking about how to bypass, challenge, or report a human gatekeeper, right? A GP who is either uninformed, biased, or just stuck in the past.
The human element is exactly where the system is currently breaking down.
Exactly. So what happens in the very near future when symptom tracking becomes fully automated? I mean, we're already seeing sophisticated AI health trackers that map biometric data, temperature fluctuations, and sleep disruption.
Oh, absolutely.
What happens when an algorithm can diagnose perimenopause with a higher degree of clinical accuracy and consistency than a human GP? If the NICE guidelines are purely symptom-based anyway, will the NHS eventually have to accept a decentralized algorithmic diagnosis when their own human doctors are repeatedly failing to spot the patterns?
It is a fascinating horizon. I mean, if the algorithm proves more reliable than the subjective judgment of a dismissive doctor, it could completely remove this battle for validation from the consultation room.
It could democratize women's health data entirely.
Yeah.
A whole new paradigm to think about. Until then, hopefully with this toolkit, you are ready to demand the standard of care you deserve.